Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In this episode, we review strategies for implementing RSV vaccines into practice with an emphasis on building vaccine confidence for you and your patients. We are joined by Dr. Jewel Mullen, Associate Dean of Health Equity and Associate Professor, Population Health and Internal Medicine at the University of Texas. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started and hear what she has to say about this topic.
It was noteworthy to me how many recommendations last June. Why didn't they just make it a formal recommendation and not just have this bring it back to us to discuss with our patients? And I understand that, and perhaps by this summer, we will have moved to that point. But the RSV vaccine is just one of the ones that fall into this shared clinical decision-making advice category: meningococcus B, MenB, HPV, PCV, conjugated pneumococcal, or others, as is Hep B for older adults with diabetes. How did we get here with a shared clinical decision-making framework was that moving from just taking the evidence to getting to a formal recommendation, the ACIP and others take a number of considerations in play. And with those, I find some that I think also lead us to where shared clinical decision-making is important. Because in addition to looking at whether or not a disease is of public health importance and whether or not a vaccine's benefits outweigh the harms, there is this other consideration around population, and then I would say individual, values around the disease and around the vaccine, and what the potential outcomes of disease are that people think about. And I think, we all went through our own version of how we dealt with patients, families, and the populations that we engage with around the COVID vaccine most recently, but also acceptability, feasibility, and the impact on equity. So the CDC's recommendation, as published in the MMWR, was that RSV vaccination might prevent substantial morbidity in older adults at risk for severe disease, and that post-marketing surveillance for safety and effectiveness will direct future guidance. And that's the point around which we had some conversation around, how many of our patients ask us to help them make a decision based on what might happen when so many of them really want to know what to do or feel confident that we are confidently sharing information and helping them decide. Checking last night, I'll just share with you that as of the 12th, April 12th, CDC reported that adults over the age of 65, 76% have had the influenza vaccine, 42% COVID, and once again, RSV has inched up just to 24%. We've talked a lot over the past few years about patient vaccine hesitancy. I thought I would stop for a moment and talk about healthcare provider hesitancy too, because I think that has a lot to say about how we engage with our patients, how we move ourselves from it's on my to-do list or no to yes, I've gotten vaccinated too, and how confidently we can actually engage in conversations with our patients when we have a lot of our own thoughts going on around vaccination, including this list of our own personal or social group influences, such as our own feelings about vaccinations and our own motivations, our own perceptions of risks and benefits, past experiences. Yes, I did get the shingles vaccine. I wish somebody had told me what I was going to feel like after. But don't let that stop you, and whether or not immunization is a social norm or needed. And then vaccine-specific issues, which also influence the way we talk with people, but influence how we practice from day to day and what's possible in the settings where we are. And study after study that I've looked at reminds us that we also need information that's useful and then information that's translatable to our patients. So with this long list of reasons for healthcare provider hesitancy, we're like our patients. And we're also influenced by other individuals, our own feelings about science, government, public health, and these other considerations that patients, and sometimes we see ourselves weighing as well. Back in 2015, the National Vaccine Advisory Committee, in a paper on addressing vaccine confidence for parents and childhood immunizations, cited that parental trust or healthcare provider trust had a lot to do with immunization recommendations, those who administer vaccines, and the process to leading to vaccine licensure. So if providers could convey to parents what the process was around vaccine development, licensure, if parents had confidence in who was administering them and had confidence in the recommendations coming from their providers, confidence rose. And confidence in vaccines is an important contributor to whether or not somebody is actually going to decide to be vaccinated. And it's going to be a contributor to how we talk about vaccines with our patients. The NVAC issued a new report on vaccine confidence following COVID epidemic. And the definition there was confidence is evidenced by a belief that vaccines work, that they're safe, and that they're part of a trustworthy medical system. So once again, both on what it takes for parents to be or patients to be confident and for us to be confident, we need to see that safety and trustworthiness, in addition to effectiveness, are all covered. So that gets to shared clinical decision-making, which is not a new concept. And even though maybe some of you remember when the recommendations for prostate cancer screening came out, and we were supposed to start talking about shared clinical decision-making with our male patients, the concept actually dates back to 1980 when the President's Commission on Bioethics cited that open communication and shared clinical decision-making require that healthcare providers have certain interpersonal skills and attitudes, and that the process it's a bilateral one between us and our patients. We have to be clear in our own minds. That, to me, includes confidence. We also have to communicate equitably and make sure that people understand what we're saying, that we're not being too jargony, that we're addressing health literacy, et cetera. And shared clinical decision-making is said to improve our communication. I think it helps improve our relationships with our patients, builds patient self-confidence and perhaps self-efficacy, perhaps satisfaction with us, more trust in us and their health outcomes. And I mean, I'm just an old school internal medicine doctor, back from the Doctors for Adults days, who wants to believe that this is not really new to what we do. Anyway, that's my ode to internists for today. So I think that in our processes of communicating with our patients, we can do so effectively without looking at a 5 or 3-step model and figuring out how to factor them into a 10 or 15-minute patient visit. Understanding that a shared clinical decision-making model, the SHARE approach to the Agency for Healthcare Research and Quality, is a process that supports providers and patients working together to get to the best decision for the patient, with the best decision being defined as the patient's confidence that they're making a decision well informed by us. And it starts by inviting patients into the conversation, the seek patients' permission to have the conversation. We've been hearing about RSV. May we talk about it? You don't have to answer that question. And then help people explore and compare the different treatment options, or at this point, vaccination options, or what it's like not to do anything at all. Ask the person what they're thinking, what they value, what's important to them, and then give them a chance to factor all that in to reach a decision. And I'm very aware, and many of you probably have had people who have said, just tell me what to do, or did I make the right decision? And I think even having this early seek and explore, help people factor things in, and this will help reinforce what they decided to do at the moment, even if the decision, as you evaluate it, might be not to get vaccinated and not to take that decision as closed, end of the discussion, but perhaps what a person is feeling at the moment. And if it's maybe not the choice I would have made if I were 65 with heart failure, here's some other information. We can continue to evaluate this. And it's the same kind of conversation that you can have on behalf of a patient with a family member if a person doesn't have decision-making capacity for themselves. For many people, shorter is better. For some people, they don't want to remember, share, or a choice, option, and talk model. But this other model, choice, talk, option, talk, and decision talk, pretty much encapsulates everything that's in the share model, in which we're still asking people to have whether they want to have the conversation, which I find valuable because sometimes people come in and say, don't talk to me about this today. And then to move on to the options, which entail both, here's what we know, here's what's available, here are different risks and benefits. And then giving them, as they decide based on their own values, what they want to do, what's most important to them. I want to get vaccinated because I don't want to be sick because I just booked a round-the-world trip or a trip to see my grandchildren, to then go through the pros, if not just the pros and cons of the decision, but also keeping open, once again, the possibility of revisiting it if the decision was not to vaccinate it. So, shared clinical decision-making. Real short and sweet.
Thank you very much to Dr. Mullen, and thank you to our listeners for joining in. To hear more episodes from this session on RSV vaccination for older adults, see the link in the show notes, and please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.